Afternoon, everybody. We're going to go ahead and get started. This is our first stab at this format using this webinar through the Teams app. So, welcome everyone. I appreciate everyone attending this. I'll give you a little bit of background about myself. My name is George Vestermark. I'm an orthopedic surgeon here at OrthoIndy with a subspecialty focus on joint replacement of the shoulder, hip, and knee. I went to Indiana University in Bloomington for my undergrad, went to IU School of Medicine for my medical school training, and then did a orthopedic surgery residency at Carolinas Medical Center in Charlotte, North Carolina, and then followed that up with a fellowship in complex primary and revision joint replacement at the Ortho Carolina Hip and Knee Center. So today we're going to talk about total hip replacement and the different surgical approaches of the hip that you can have. So with that being said, we're going to get started. We already have some questions on the queue that I'll try to address with this presentation, as well as try to answer any other questions at the end of this talk. Feel free to chime in and write any more questions real time through the link that Ashley is going to have on the side of this presentation here. So we'll go ahead and get started, and just bear with us here. Get this presentation up. Let's see, content, there we go. Send live. You see that? We got it here. All right. Okay. All right, so just a brief overview. We'll talk a little bit about the anatomy of the hip and common causes of hip arthritis, I should say. We'll go over kind of the initial evaluation and treatment options for hip arthritis, and then when is it time to consider hip replacement surgery. And then lastly, we'll talk about surgical approaches of the hip. So the hip is one of the body's largest joints. It's a ball and socket joint. The socket is formed by the acetabulum, which is part of the pelvic bone. And the ball is the femoral head, which is the upper end of the femur or the thigh bone. The bone surfaces of the ball and socket are covered with a smooth tissue called cartilage that cushions the ends of these bones and enables them to move freely and easily without much friction. Surrounding the hip and containing the hip joint are strong bands of tissue called ligaments, which makes up the joint capsule that you can see on the right side of this image, which connects the ball to the socket and provides stability to the joint. Arthritis of the hip is a condition in which the cartilage or the cushion of the hip thins or wears away with time. When the cartilage wears away, the bone is forced to rub against the bone in order to move. And this can be extremely painful and can cause stiffness around the joint, swelling, and even some inflammation. So it's important to note that hip arthritis is a progressive process, meaning that once it starts, it will continue to wear away with time and will not get any better on its own. There are a number of causes of hip arthritis, including the most commonly called osteoarthritis, which refers to wear and tear. There's rheumatoid arthritis, which is also a common cause of hip arthritis. You can have post-traumatic arthritis if you've had a previous injury or you broke a bone in the hip. Osteonecrosis just refers to the loss of blood supply to the hip. This can be seen with certain conditions, such as in patients with sickle cell disease or that are on long-term steroid use. And then lastly, childhood or congenital hip disease, most commonly hip dysplasia, can also lead to hip arthritis. Total hip replacement, also known as total hip arthroplasty, has been one of the more common elective surgical procedures in the U.S., with over 350,000 Americans getting hip replacements per year, and this number is expected to double over the next 20 years. With this surgery, the damaged bone and cartilage is removed and replaced with specialized prosthetic components. The damaged femoral head is removed and replaced with a metal stem that is placed into the hollow center of the femur or the thigh bone. And then a prosthetic ball or head made of either a special metal or ceramic material is placed on that upper part of the stem. And this ball replaces the previous damaged femoral head that was removed. And then the damaged cartilage on the socket side is also removed and replaced with a specialized metal socket. As you can see on the right here, this is an example of a hip replacement prosthesis. Screws are sometimes used to hold the socket in place. And then lastly, the final piece is a specialized plastic that's inserted between the new ball and that new metal socket, which allows for a smooth gliding surface. In terms of an evaluation, the initial evaluation starts with a thorough review of the medical history, including any risk factors and injury history. The physical examination includes first inspection of the skin, as well as assessment of the hip range of motion and the overall muscle strength, as well as just assessing the patient's gait and if they have any limp associated with their hip. We also oftentimes examine the spine, as this is also often can have overlapping and similar symptoms if you have underlying spine disease. X-ray imaging is always a part of the first kind of evaluation, and this will confirm if arthritis is actually present. You can see here these two images. The side-by-side image on this slide demonstrates kind of the progression of arthritis indicated by the arrows. You can see the normal joint space that you would see between the ball and socket on the left, and then what happens, what I would call it the most advanced stage of arthritis, where there is complete loss of that space and the bone is rubbing the bone, and you can see changes occur to the surrounding bone with bone spurs and so on and so forth. In terms of treatment options, you know, the first line treatment we use are oral medications with anti-inflammatories such as Tylenol, ibuprofen, Aleve. In some scenarios, when the hip is not severely worn out, we often offer physical therapy. Ultimately, what needs to happen is the patient needs to experience some lifestyle changes, unfortunately, modifying their activities. For example, if they enjoy walking for exercise, they may want to transition to more low-impact exercise, such as riding a bike, a recumbent bike, or a stationary bike. Another option to help with symptoms is using a walking aid like a cane to help kind of offload the stresses to the hip while they're walking. And then also we encourage patients to try to lose weight, which we know is directly related with kind of progression of the arthritis. Lastly, a hip injection is another viable option if the hip is, again, not severely worn out and not at the latter stage, but in kind of more the mild or moderate range. A hip injection, similar concept as kind of the oral medications. A steroid is injected actually into the hip capsule, hip joint, and that decreases the inflammation and hopefully helps alleviate the symptoms. Now, it's hard to predict how long a hip injection can last. Some last for several months, some only last for several weeks. So when is it time to consider hip replacement? Ultimately, when the patient is experiencing still persistent pain, stiffness, and really dysfunction despite these treatments I just mentioned, and it's become a hindrance on just doing everyday activities such as just walking a few blocks, or particularly using the stairs and doing basic things you often overlook, such as just bending over to tie your shoes or standing from a low seat or getting out of your car even. Ultimately, I tell my patients this is a kind of a quality of life decision that you'll know when it's time, when you're thinking about your hip day in, day out, and it's limiting the simple things that you do in life. That's when you make the decision to go forth with surgery. And again, this is based on pain and dysfunction and not age. So in terms of just big picture recovery, once once my patients decide to undergo surgery. Surgery takes about an hour itself, and most patients stay one night in the hospital, and they're putting full weight on it day one. There are some restrictions, and we'll go into that when I talk more about the approaches, depending on the type of approach, but patients are putting full weight, working with physical therapists in the hospital. In terms of using a gait aid, most patients are using a walker for around 5 to 7 days. After that, as they get more confident and more conditioned, they transition to a cane for another 5 to 7 days. By 2 or 3 weeks, patients are mostly off all walking aids. There is no, in my hands, patients do not need to do outpatient physical therapy unless they request it. Unlike knee replacements, hips are rather forgiving and do pretty well with the home exercise program. So you'll have, actually you can see on this slide here an example of my protocol that I would give my patients before surgery, with expectations they would do this on a daily basis. In terms of driving, cannot drive for roughly 3 weeks until you get your reaction time back, and patients must be off all narcotic pain medications at that time. As far as expectations for return to work, generally speaking, if you have more of a desk job, a sitting job, expect to go back by 4 weeks. If it's more labor intensive, it's closer to 6 to 8 weeks. That's not a hard cut, but that's a general kind of guideline. So kind of moving on to the different surgical approaches, there are a number of different approaches and variations on how to access the hip joint. The two most common approaches used by hip surgeons in the US are the direct anterior and posterior approaches. I utilize both approaches in my practice, and so for the purpose of this talk, I will focus on these two. You can see the last, the third bullet, the lateral or anterior lateral approach is also used and is a variation between the two, but is used less frequently in the US. So roughly 90% of my cases are via the anterior approach, which means I access the hip joint in the front of the thigh. The other 10% I utilize the posterior approach, and this is when the surgeon accesses the hip joint from the back. So with the direct anterior approach, the patient is positioned on their back on a specialized operating table in the OR. I typically make a 4 to 6 inch incision at the front of the hip, or generally speaking, it's kind of at the front of the thigh. This incision typically just starts below the pelvic bone and extends toward the top of the thigh. And so with this approach, you're able to access the hip joint by moving muscles aside along their natural tissue planes and without splitting muscle or detaching any tendons. And so the main advantages and the reasons why this is my preferred approach are the following, really. First, it allows me to use an X-ray machine easily in the operating room, which allows me to be very precise with placing the implants and the prosthetic components. Secondly, it allows for a little bit quicker recovery. Studies have shown that patients are off walking aids a little bit quicker than going via the posterior approach. And I think that holds true to the fact that we're again going in between the muscle as opposed to splitting the muscle. And lastly, there are no restrictions after surgery. There is a slightly lower risk of hip dislocation going anterior as opposed to posterior, although both approaches have very, very low dislocation rates in general. Disadvantages of going via the direct anterior approach: it does require a specialized kind of operating table and equipment. There is a risk of having some numbness or even an occasional burning sensation on the thigh after surgery, because there are a branch of nerves that go over the skin in this area, although this does not cause any functional limitations if this occurs. And lastly, in certain body types, there is a little bit slower wound healing. With the posterior approach, this is a little different in that you're positioned on your side typically during the surgery. The incision roughly is 6 to 8 inches, and this occurs generally between the side of your hip and the back side, kind of splitting the difference between the two. Advantages of this approach: it allows for better visualization of the hip joint. And so this is often needed in certain complex cases where a patient's had a previous surgery to the hip, or there's hardware or metal in that area, or in the setting of what we'll call a revision case, where a patient's already had a hip replacement and there's something that's gone wrong. This is an approach when I'll utilize posteriorly. Another advantage is more predictable wound healing in all body types, really. Disadvantages, it is a muscle splitting approach, and kind of going back to the recovery. In the short term, the early recovery phase, patients tend to be on the walker and the cane slightly longer than the anterior approach. And there are more restrictions after surgery because the risk of dislocating is slightly higher than the anterior approach. So restrictions meaning the first 6 weeks after surgery, patients can't bend their hip past 90 degrees and they can't cross their surgical leg over their other knee. Again, this is not a long-term thing. It's a temporary kind of restriction and protocol for the first 6 weeks. So just to kind of summarize, total hip replacement is a proven surgical procedure for the treatment of hip arthritis with goals of alleviating pain and restoring function for the patient. Both approaches I discussed have excellent outcomes, and ultimately it's a discussion you should have with your surgeon about the approach options. And really, surgeon experience and preference are important considerations when deciding which approach to use. So with that being said, this is the link, right, Ashley, where you can chime in and add some more questions. If you have any other questions I didn't address, bear with me for a second here. I'm going to pull up some questions we already have, and I'll go over those. While if anyone else wants to add any more questions, we can do that as well. All right. So me summarize. All right. So we have a couple questions here right now. The first one is, I have interior and exterior hip pain. I've been diagnosed with an inflamed IT band and arthritis. Will hip replacement surgery fix that? And so that's a great question. IT band syndrome is a common condition we see in our clinic, and oftentimes it resolves with some certain exercises, sometimes some physical therapy, and that can be indirectly impacted by hip arthritis. So to answer the question, hip replacement surgery addresses the hip arthritis, not the IT band syndrome, but indirectly can help in terms of alleviating those symptoms that come with inflammation on the side of the hip there. So let's see. Second question, what is the cost of a hip replacement? So this number can vary on a number of factors, including, geographic region, what type of insurance you have, whether that's Medicare or commercial insurance, the terms of the insurance, but on ballpark, on average, the total out-of-pocket cost for patients for a hip replacement is around $1,500. Again, it depends on different terms, what your deductible is. That average or that range can go anywhere from zero out of pocket all the way up to $8,000. So hopefully that gives you some ballpark kind of estimate there. If you want more information, you can always call your insurance provider to get a more realistic quote, but that's generally the average out of pocket for our patients. Next question, if the pelvic bone is spongy before surgery, what stops it from being spongy post-op? So I'm assuming, so by spongy you mean the bone density. There's a lower bone density, which we diagnose patients with what's called osteopenia, or sometimes the more severe form, which is osteoporosis. Now, the hip replacement doesn't address the bone density, but if the arthritis has been causing our patients to not be active and not put a lot of weight on the hip, that we know directly impacts the kind of the quality of the bone density. So when the hip replacement's done, it's safe to assume the patient becomes more active, which will help with the overall bone quality. And that kind of goes to a second point. Depending on the quality of the bone in the operating room, sometimes we will use other resources or other screws or what's called cement to kind of reinforce the implant if the bone quality is poor. Next question, what are the, I think we kind of addressed this one, but what are the benefits, risks, and challenges associated with an anterior approach hip replacement? So again, just to summarize the benefits, you know, I find are quicker recovery in terms of no restrictions after the surgery. Challenges, it depends on the body type. Certain patients, in my practice, I will utilize the posterior approach if they have an excessive kind of skin fold in that area that's going to cause wound healing issues. So that is one factor to consider. Let's see, another question we have is it not okay to use a walker with a seat after surgery, and why? I don't have any restrictions as far as that goes. Typically, we have actually a nice streamlined class patients go to before surgery. It's called our total joint class, where it's run by one of our nurses that's actually had a hip replacement, who will give different resource links on getting your walker lined up before surgery. Most important thing is you just need to have a walker to be safe, because we don't want you falling in those kind of early first few days while you're recovering from your hip surgery. All right, so do we have any more questions? Ashley, okay. Okay, well, thank you everyone for attending, and hopefully this was informative. If you have any other questions, feel free to give my office